Thank you, everybody who's made time to participate this afternoon. Surreal, will you switch to the next slide, please? So first, just wanted to kind of go through an overview of the Maternal Hypertension Initiative just briefly. Our aim to reduce the rate of severe maternal morbidities in women with preeclampsia, eclampsia, and preeclampsia superimposed on pre-existing hypertension by 20% is still our goal. Go to the next slide, Terrell. Okay, in the structure measures, we didn't change anything in the structure measures since the last time. And next slide. Do want to remind everybody in process measures, though, one of the things that has been added is in P2, provider education, the number who completed education on preeclampsia, but also the number who completed training on implicit bias. The same with P3. And we'll go into a little more information about that in just a second. Okay, next slide. And the goals by 12/2021 and be able to have a 20% reduction in the number of women with severe maternal morbidities, and time to treatment improvement, 100%, 100% debriefs on all new onset severe range hypertension cases, and 100% discharge education and follow-up within 7 to 10 days for all women with severe range hypertension. Okay, next slide. I do want to spend just a few minutes on the reporting requirements. So we sent everybody, and hopefully you all received the new reporting template for the quarter that you've just reported on that ended at the end of September. All of those reports were due by the end of October. I know Terrell has communicated with the hospitals that haven't sent a report so far, and really asking that we get all of the reports in by close of business on Friday. We did have, between some security measures with our IT system and then with some of the facilities that are receiving the templates from us, we did run into some glitches with the whole email sending of the documents early back in October. It did prompt us to realize that it's time for us to look at a way that we can share out information without having to depend on direct emailing of documents, since there are so many security things in place that cause problems for lots of people. So we are exploring how we're going to do that. We did post this new reporting template on the website, and we will continue to do that every time there's a change made to the reporting template. So that will always be a resource, but looking at something in addition to that. So just to briefly go over this, I don't want to hold up any of our great speakers. For provider education and nursing education, P2 and P3, the measures for implicit bias training are added there. And those will begin to be reported on in the first quarter of calendar year 2020, January through March. And so remember, one of the, we selected the bundles that we're working on based on maternal outcomes in our state, hemorrhage and hypertension-related deaths being two of the leading causes of death, and also for a lot of severe maternal morbidity. And the reason that implicit bias is being added is the collaborative has made a decision to incorporate more health equity measures and a real focus on health equity into all of the work of the collaborative. And this is one of our initial first steps to implement something. It is a very tiny first step, and we'll need a lot more going forward. But for for the hypertension and also for our hypertension bundle, we've added the training measure for implicit bias to start moving in that direction. Implicit bias training is not it's definitely not the end of where anything needs to go, but it is a measure that can help start conversation and raise awareness. So it's definitely something that we want to have included. That won't be reported on until the first quarter of 2020. And for P4 and P5, there's just reminders on there that we'll begin to report on them during that same quarter. Go to the next slide, Terrell. And no changes to the structure measures, so I'll ask you to go to the next slide. I wanted to talk just briefly about this. I've got this document up just really for a placeholder to keep this conversation going. For the P4 and P5 measures that are related to time to treatment, case identification, we needed to have a mechanism in place to collect some additional information out of the patient record and how to report that back. So there is a work group that's working, I believe Lauren Nunley is working with 5 hospitals that have volunteered to kind of put together what form that we can kind of recommend out of the collaborative that hospitals can have as a tool to use or to modify for their use. But we are also working on and that work is supposed to be completed at the end of November. We will use the next couple of months after that internally here at Department of Public Health to expand on a reporting system so that hospitals can enter this information directly into the reporting system and also as a way to start submitting quarterly report information. So more to come on that. Just wanted to let you know what we're working on. Will you go to the next slide, Terrell, please? We're going to be providing a lot more information, obviously, in the coming months. I wanted to go ahead, though, because some of you have already reached out about what maybe some of the resources are as you're starting to consider, how your hospital can implement implicit bias training. What does that look like? And so we had some resources. There was a subcommittee that worked on kind of putting some resources together over the course of the last year. That work is now being incorporated into the collaborative as a whole. But I've listed a couple of the resources that they identified and for your consideration. One is implicit assessment test that's available through Harvard. It's pretty widely known and used, definitely something that you can take a look at. I wanted to talk briefly about some of the other resources that we're looking at. The committee also identified some training that had been available through the Association of Medical Schools. And when I reached out to them, to more information, what would that look like? Could you bring it to Georgia? They had contracted with a vendor, Cook Ross, and their contract is currently lapsed, but they put me in contact with Cook Ross directly. So I am working with that company on what kinds of things could be we could bring to Georgia to provide hospital staff who's interested with more resources around this. So some of the things just for now that we are considering is maybe having an introductory kind of presentation at our annual meeting in April. Also what kind of online training resources they could help us develop, and a train the trainer course, just kind of high level. It was like as the course exists that they provide now, it's about a 3-day course. There is a possibility to bring that to Georgia, and so we're working on pricing and what kind of things that we could offer through that. So just please stay tuned. I think in the meantime, just begin to review your hospital information and resources around implicit bias training. Begin to have internal discussion. Review any policies you have. Consider developing policies if they're not in place. And then just consider how you can maybe use things like the implicit association test in your facility to begin this work. But please stay tuned for more information about that. Before I move on to the first speaker, is there any questions about any of that stuff? I went through it pretty quickly for the sake of time. Okay. We are very excited to have Rebecca Britt from the Preeclampsia Foundation to speak. She is the Director of Education and Engagement for the Foundation. Her calling to advocate and support those who often don't have a voice led her to earn a Bachelor of Science in Social Work from the University of Vermont. Rebecca is really passionate about reducing isolation for preeclampsia patients and survivors by building community connections and raising awareness. She's a visionary and a global thinker and currently earning her master's degree in program evaluation in hopes of providing the Foundation the best strategy for collecting data and demonstrating impact of their programs. Upholding the Preeclampsia Foundation's mission, Rebecca aims to provide the education and tools necessary to empower patients to advocate for systemic change to save lives. So we're very excited and appreciative to have you here today, Rebecca. Welcome.
Thank you so much for that great introduction. I'm so excited to be here, and of course I feel like education is a huge piece in reducing some of these adverse outcomes. So hopefully I can teach you more about that today and help you understand how critical it is to kind of reducing some of these adverse outcomes. Next slide. So today you're going to learn about why educating all pregnant women about preeclampsia signs and symptoms is important for timely diagnosis of disease. You'll be able to utilize two methods for ensuring patient understanding of the information, and you'll be able to convey appropriate information during prenatal and postpartum periods. Next slide. So what is preeclampsia? It is a hypertensive disorder of pregnancy, and it typically occurs after 20 weeks gestation and up to 6 weeks postpartum. There's no cause, no cure, and at the Foundation we always like to remember that it's any woman, any pregnancy. Next slide. So how preeclampsia is diagnosed with current guidelines is a blood pressure reading of 140/90. That's 2 readings 4 hours apart with the ACOG guidelines, or 1 reading of 160/110, and the presence of protein in the urine, or if there's no protein in the urine, in association with new onset low platelet count, impaired liver function, poor kidney function, fluid around the lungs, or visual disturbances. Next slide. So a little bit about the prevalence of preeclampsia. 2 to 8%, or approximately 1 in 25 pregnancies, are complicated by preeclampsia, even more for hypertensive disorders of pregnancy. It's a leading cause of maternal morbidity and mortality. African American women are 3 times more likely to die from preeclampsia, and 75% of preeclampsia-related deaths happen in the postpartum period. Next slide. So in our work here at the Foundation, we've kind of over our years boiled down the top 5 reasons providers don't educate their patients about preeclampsia. And these reasons are: there's not enough time. Patients already get too much information, so there's already so many things that you have to tell a patient about that preeclampsia kind of falls to the bottom of the list. They're afraid that their patients can't absorb it all. They're already anxious about their pregnancies. They don't want to make their patients more anxious. They feel as though materials are not written at a low enough grade level for for the patients that they see, or their patients only speak Spanish, or some clinics don't have a budget for patient education materials. Next slide. So some challenges associated with preeclampsia. It's a syndrome, so it's not a defined disease entity, and the diagnosis doesn't predict the outcome. So we have people call us all the time and say, I was just diagnosed, I'm 24 weeks, how long do I have? And it doesn't really work like that. It could be, we're going to, it's rapidly progressing, so we're going to induce you soon, or you might last to 39 weeks with proper management. So it doesn't, the diagnosis doesn't necessarily predict the outcome. Often it's a misdiagnosis, so we get this all the time that, the woman's blood pressure was just high because of white coat syndrome. It's neurological, she's complaining a lot, maybe it's gallbladder pain. I've heard, you have a urinary tract infection, stuff like that. So the diagnosis is missed often. Best prenatal care leaves huge gaps, right? Like a month at a time at the end, but even more time, or each week at the end, but even more time, like a month in between earlier in pregnancy. So if it's a rapidly progressing disorder, you can start to have symptoms and be in a very critical position way before you're scheduled to go see your doctor again. There's two patients that must be considered, right? We have the fetus and we have the mom. So we have to weigh the health of both, which definitely poses a challenge. And then the symptoms, probably the most confusing one, is that the symptoms aren't unique to preeclampsia, right? So women who have these symptoms often mistake them for regular pregnancy symptoms because they are. They're just more severe. So that's definitely a major challenge. Next slide. So the symptoms, we'll go over them real quick, that women need to know about are swelling of the face or hands, a headache that won't go away, visual disturbances like floaters in the eye, flashes of light, blurry vision, stomach or upper right quadrant pain, nausea and vomiting that is reported after 20 weeks gestation, sudden weight gain like 5 pounds in a week, breathlessness, so not being able to get a cleansing breath, feeling like somebody's sitting on your chest, and just not feeling right, or unexplained anxiety. Next slide. So patient education, does it really matter? Well, it does, because the patient is often the first responder, right? So they can speed up time to diagnosis if they can recognize the symptoms, and then they can impact their outcomes. Of course, the sooner we get somebody diagnosed, the sooner we can treat them. What she knows about isn't, what she needs to know about isn't obvious. So we can't judge what somebody should know or would know by the way that they look, or the way that they act, or the way that they talk. We do need to just educate everyone on the same basic level. If she understands the seriousness of these symptoms, she's more likely to report, and she's more likely to take them serious herself or go get her blood pressure checked. We also know that patient education is currently not routinely provided by healthcare providers, and when it is, the information is often not understood. Next slide. So in a 2012 study on factors associated with patient understanding of preeclampsia, only 14% of the patients were able to provide characteristics that correctly reflected preeclampsia, and patients correctly answered only 43% of 25 relatively simple questions about preeclampsia. This was done at a clinic over a 10-month period of patients that came in, so pretty low numbers as far as awareness of preeclampsia or what to look for. Next slide. And what we do know is that 60% of maternal deaths due to preeclampsia are preventable. Next slide. And so the deadly consequences, there are deadly consequences in not providing patient education. Based on the CMQCC data, the maternal mortality review of over 200 cases of pregnancy-related death, delays in seeking care appear to be directly related to fatal outcomes. And a common theme in these cases reviewed was that there was an apparent lack of knowledge of the significance of the symptoms and when they should actually seek medical attention. Next slide. So when women know how to recognize the signs and symptoms and they understand the explanations offered, they are more likely to report symptoms and comply with prescribed treatments. Next slide. So this is kind of the ideal pathway, right? Patients understand and recognize symptoms of preeclampsia. They go ahead and seek care. The providers are able to provide the correct treatment, and there's an improved outcome for mom and baby. And Dr. Savai says the best way to diagnose preeclampsia is to listen to your patient. Next slide. But it's not that easy. And this is a video, but I'm just going to tell the story in case we aren't able to play it. So, so this is Demi's story. Oh, do you think that it would work? Or that's fine. You can just leave it there, and I'll just tell the story. Okay. Okay, so this is Demi's story. Demi is the younger one in this picture. She was 32 weeks pregnant, expecting her first baby with her fiance. You can try, if you want to try to play it. I don't know if that's what you're trying to do. There you go. There's no sound. I'm not hearing any sound.
Yeah, we don't have it.
Okay, that's fine. I can just tell the story. So
okay.
While it plays, that's fine. She was 32 weeks pregnant. She didn't feel right. She went into the doctors, and she had swelling in her hands and her face. She was given blood pressure medication. She had high blood pressure, but she was sent home. And later that night, her husband woke to her seizing in the bed, and he immediately called the ambulance, and she was turning blue. He called her mother. She died on the way to the hospital. They did an emergency C-section right away at the hospital, but there was brain damage suffered by the baby. And Demi's husband, who had just lost his wife, had to take the baby off of life support within 4 days of his wife's death. So you could think that this maybe is a demonstration of, not a demonstration for patient education, right? Because she actually knew her symptoms and she reported them and she was sent home. So this happens over and over again. We hear about women reporting their symptoms and being sent home or not being taken seriously, being brushed off. So I'm going to have you just advance. So, and advance one more time. But the reason why I bring this up in patient education is it's found that patient education actually reinforces provider education. So in Jamaica in the mid-90s, there was a large intervention study aimed at reducing the incidence of eclampsia. They had very high numbers of eclampsia. And so if you go to the next slide, they actually distributed this easy pictograph, simple patient education material because they had found in their research prior to the study in their lit review that women actually didn't, even though there was a high education level of the women, they didn't care to read or they weren't comprehending written material. So they came up with this this kind of simple pictograph, and what they found is that this lowered the eclampsia rate 70%. But what was interesting about the study was it wasn't necessarily because women knew to respond, but it was because providers were going over this stuff often with patients. Their response was a lot more appropriate when a woman would call. And I had a patient call into the foundation the other day, and she said that she had had a C-section. She had been sent home. She was experiencing a headache that would not go away in the postpartum period. Well, all she knew to think of was a spinal headache. So she called her OB several times and said, I have the worst spinal headache that won't go away. And because she was labeling it a spinal headache. I'm just guessing here, all an assumption, but I'm guessing that may be why the triage nurse assumed it was a spinal headache too and said she'll be fine, take some medication. She called 2 more times and she was told to just relax. And it wasn't until she went on Facebook and somebody told her to go get her blood pressure checked that she realized that her blood pressure was very high, and she reported to the ER. So the thought here is that had that nurse that was on the line constantly been giving this this patient education, then the nurse would go, you know what, a severe headache that won't go away is one of those symptoms, and I'm going to have her come in. So patient education is not just patient education, it reinforces provider education as well. Next slide. So that's why, and now we're going to go into the when and how. Next slide. So for prenatal education, at 15 to 20 weeks, you want to start providing printed materials. Remember, printed materials are great for, especially the concern that patients don't comprehend everything in their visits. If you can give them something to go home with that they can reference back to and understand exactly, oh, right, these are the symptoms and this is what I'm supposed to do with it. At these 15 to 20 week appointments, you can also assess your patient's health literacy. Does she understand? And you want to do that by kind of asking her to teach back to you. At 20 weeks, you want to review warning signs often for women who are considered at risk and occasionally for women at low risk, and checking for understanding. So this is a big one, asking women explicitly, have you experienced whatever the symptom is, rather than how are you feeling? What are your symptoms? If you say, have you experienced any visual disturbances, or have you experienced any blurry vision? Have you experienced any swelling in your face and hands? Have you experienced any severe headaches? Being very explicit, because a woman might not know that something is worth reporting. And then check proper behavior response. So, okay, it's great that you haven't experienced any of those. What would you do if you did experience? And then hand them take-home reminders and hard copy materials. For outpatient management, make sure that patients know all the warning signs and symptoms, and then exactly what to do when she experiences them. Every place is different. Sometimes you want them to refer to L&D, and sometimes you want them to call your office. So taking into consideration that and making sure they know what to do, and using that, what would you do if you experience, to make sure. And then always considering geography. So how long is it going to take them to get to care? Are they going to need to get on the MARTA or something to get to you, or take the bus? How long is this going to take? So make sure that you're understanding geography as well. Next slide. So key strategies for effective patient communication. Again, don't assume your patient's literacy level or understanding by appearance, and this is easier said than done. Like, it's obvious that, okay, yes, I'm just going to talk in plain language, but I'm the director of the education of the Preeclampsia Foundation, and I will be at a conference with a booth, and a patient will come up to me. I had this happen recently. Patient came up to me and said, "Oh, preeclampsia, what's that?" And I said, "Oh, it has to do with hypertension and pregnancy." And she said, "Is that high blood pressure?" And I couldn't believe, like, thank God she was willing to ask a clarifying question, because otherwise she would have left my booth and actually had an interaction with the Preeclampsia Foundation and still had no clue what preeclampsia was. So it's easy to make these mistakes and kind of speak in the language that we use every day, right? So using that plain non-medical language, high blood pressure, preeclampsia alone is a really scary word. I don't think I knew how to spell it, you know, until 3 months into my employment. So make sure that you're slowing things down and speaking on their level. Organize information into 2 or 3 components. So what is preeclampsia? What are the risks? What to look out for? What to do? And our tear pad, which I'll show you at the end of this, kind of breaks it down into those components. And then use teachback to confirm understanding with open-ended questions. Again, what would you do if you were to experience any of these symptoms? Next slide. So this is your patient education toolkit here. We have everything you should need on preeclampsia, posters and tear pads, brochures. We now have a postpartum tear pad, which I'll talk about, and new is also this Ask About Aspirin. Certain women with certain risk factors are indicated for aspirin therapy, and so we have our Ask About Aspirin rack card as well. Next page. Okay, so our preeclampsia tear pad. Each tear pad has 50 sheets. I hope you guys are familiar, most of you are familiar with this. It's out there, but each tear pad has 50 sheets. They're double-sided with English on the front and Spanish on the back. What's interesting about these is that the colors are actually evidence-based. So there's research behind these colors. We didn't just choose them to be kind of ugly on purpose. They actually stand out for women rather than the blues and the pinks that you see in maternity. These have been tested to catch a woman's attention. The illustrations also and the language are also targeted to low literacy audiences. And again, using these to have the chunk and check, the what is it, risk to you, risk to your baby, signs of preeclampsia, what should you do, all very clear. And if you go through that, it increases patient and provider awareness. Next slide. And this is our postpartum preeclampsia tear pad. Great for use in hospitals during discharge, for at-risk patients right before delivery as well. Same as our other tear pads. They're English on the front, Spanish on the back. And the illustrations and language, again, are low lit. And this can also easily trigger early follow-up appointments. If you want to make sure a patient is going to be seen by their OB within a week of discharge, this would be the time, kind of while you're going over this, to advise on that. Next slide. So with our postpartum initiative and the tear pads, we actually also have launched the wristbands that can go on women's wrists that say preeclampsia and then stillatrisk.org on the back. We're really trying to debunk this delivery is the cure myth. We know that 75% of preeclampsia-related deaths happen in the postpartum period, so this is kind of, and I meet healthcare providers and nurses often that say, oh, I didn't even know that it could happen postpartum. So we have a big push for postpartum education This is a really vulnerable period. It's exacerbated by postpartum depression. Especially if it's somebody's first kid, they feel like a lot of this is just normal. They're tending to their baby. They don't have time to run to the clinic or run to CVS to check their blood pressure. So this is a
Rebecca,
yeah.
Can you get a little bit closer to the phone? You're kind of going in and out a little bit there.
Oh, sorry about that. Is this better?
Absolutely. Thank you.
Okay, great. Sorry about that. So same warning signs as preeclampsia, and it can happen up to 6 weeks postpartum. As you know, health systems are not optimized for postpartum, so make sure your patients know where they're returning. Are they returning to L&D? Are they going to the ER? If they're going to the ER, are they reporting that they're recently pregnant? These are things that women need to know if they're at risk for postpartum. Make sure your discharge instructions are clear and inclusive. Okay, next slide. We also have patient education videos, so you can view these at preeclampsia.org. They're also on YouTube. Have your patients watch them before discharge. Right now we have the 7 symptoms every pregnant woman should know, ask about aspirin, and our postpartum preeclampsia video. Next slide. So in summary, prenatal and postpartum patient education about preeclampsia is recommended for timely diagnosis and improved outcomes, supported by the bundle, supported by ACOG guidelines. Ensure comprehension by using proven techniques, chunk and check, teach back, use the illustrated symptoms care pad. And I just want to make a note that women want and need this information. There's a myth out there that women don't really want to hear about things that might be scary, but we hear over and over again that women do want to be empowered. They wish they knew that they could check their own blood pressure. They wish they knew what preeclampsia was and what to look out for, and that things could have been just so different for them and their family if they did know. So women do want and need this information. All right, I think that's all I've got. Oh, and this is where you can get our patient education materials, preeclampsia.org/store. And I don't know if there's a follow-up email going out after this, but we could maybe include that link.
Yes, we can certainly include that link. Thank you. That was an excellent presentation. And this may be a follow-up conversation and not anything on the call, but it would be good to explore if you had ever considered having any kind of co-branding on any of your materials, and we can talk about that offline, but because they're absolutely wonderful materials.
Yes, and I will just say that we have discussed on like a per kind of like a per organization or per entity basis what co-branding can look like, so we're definitely open to that.
Okay, thank you so much. Are there any questions for Rebecca? And I'm sorry I've gotten away from the chat to see if I can see anything there. Oh, yeah.
Hopefully there wasn't too much saying they couldn't hear me.
I don't see that at all.
Okay, good.
Okay. Well, thank you again. Thank you again, Rebecca. That was just excellent. We really depend on the Preeclampsia Foundation as a valued partner, and in our GaPQC, serving on the advisory council, and great participant at our annual meetings, and for whenever we have a need like this, just to bring some education to the participating hospitals. So thank you again.
Thank you. Thanks for having me.
Okay. The next presenter is from, or presenters, I think, is from Novacent Regional in Macon, the Regional Perinatal Center there. Jennifer Boland, the Maternal Outreach Educator, and Diana Woodham, the Maternal Transport Coordinator, wanted to share a couple of resources that they use in their facility around patient education. So if you could put that slide up, Terrell. Thank you. Diana or Jennifer or both?
This is Diana Woodham. Thank you, Diane, for asking us to share our education. This first slide is our post-birth warning signs card, and we have magnets to match. We have to give kudos to Piedmont Columbus for sharing this with us and allowing our marketing department to put our own touches on it. They are 2 5x7 cards printed out on heavy cardstock. One side is printed in English and the other is in Spanish. We also have 5x7 magnets both in English and Spanish. Our patients receive a discharge folder that contains all important documents regarding their discharge, education, and follow-up. So we place a card and a magnet in each folder, and the nurses go over the information in the folder with the patients during discharge teaching. Next slide, please. These are our discharge instructions for patients with hypertension and preeclampsia. We give these to patients when they are being discharged. We were able to utilize the discharge instructions from the resource page from the CMQCC website. Our MFM reviewed the instructions and made a few changes. We then took the discharge instructions to our quarterly physician meeting where the physicians reviewed the instructions and voted to implement them on the unit. Once we received our approval from the physicians, we went to the medical executive committee and obtained approval there. From there, we had our DCI and our IT teams work on placing the discharge instructions into the DPART process in Cerner. Now the nurses can search and add the attached discharge instructions to the patient's discharge in the EMR. The discharge instructions refer to following up with a physician in 7 to 10 days and when to call their doctor for certain symptoms as elevated blood pressure, dizziness, headaches, and so on. Those are our 2 forms. Is there any questions?
Okay. Thank you so much, Diana. I wanted to, and the great materials and great resources. I wanted to, so this is given, the warning signs information is given to every mom at the time of discharge, correct?
Yes, it is. It's placed in a folder along with the other discharge instructions, and it's given to all. This hypertension and preeclampsia discharge instructions are given just to patients who have been admitted with those problems. Okay.
I think one of the things that that Rebecca shared with us in terms of, patient, excuse me, being aware of the absolute importance of when they return to the emergency room or to anybody that wasn't their OB provider with some, symptoms that could indicate some issues is the need to say that they just had a baby, or even if it's, been a couple of months, that they always do share that information. So I think we can't do enough to kind of get that message out there.
Mm-hmm.
Also, I think where there may be still some opportunities, and some of this is a cost issue, is Rebecca said patients weren't aware they could take their own blood pressure, and is that something, we need to be more, to have expanded in the state, is the availability of resources for patients to do that, know how to do it, and providers be supportive of that practice.
Yes, and there are places they can go have their blood pressure taken if they don't have the equipment, so we can, try to provide that information for them also.
Yeah, that's a really good point, where those resources are. Okay, thank you. Are there any questions? I'm not seeing anything in the chat box, so you want to put up the next slide, Terrell, please? I just want to briefly go over this, the next educational offerings for the hypertension team. December 3rd, the webinar will include information about clinical simulation drills, how to implement the process, kind of some guidance there. January 7th, it will be complications and special circumstances that will be presented. And then February 4th, outpatient management of preeclampsia. March 3rd, partnership with the emergency department, which I think we all know is greatly needed. I did want to spend just a minute, and please use the chat box to offer in your comments or email us afterwards, because we'd love to have your feedback on the regional training that we're planning. We have just finished, myself and working with the Regional Perinatal Center maternal outreach educators, a survey document that will be sent to all of the hospitals in the state to kind of get, it's about, I think it's only about 9 questions. Interest in participating in regional face-to-face clinical simulation drill and debrief trainings. When we polled our hemorrhage team, kind of at the end of their first year of rolling out that bundle and asked, what do you want to hear about next? It was kind of overwhelmingly drills and debriefs, more information on that. So I think even for people who already have a process in place, how it could be done better, more efficiently, just to learn and gain more ideas. So we are planning to do that. I think we're looking at kind of something maybe around the end of February. Our plan is to get the survey out this week to find out, to see just what the interest is in the state, to determine, when and where to have them, and to kind of place them strategically where people indicate that there's a need and would be able to travel. So would love to hear any questions or just suggestions now or after. Okay. So Lauren Nunley is on vacation today and not on the call, but I will ask Dr. Kotke, if you're still on the line, if you had any comments before we end out today's session.
No, I think that was really just wonderful content. And I want to thank both of our folks that presented. It was really helpful and pragmatically useful for educating patients. I'd like to reinforce one of the things that you said, Diane, about making sure that we educate patients to educate the people that are taking care of them, that they did just have a baby. We had talked with some of the EMS folks, and it's not always on their list of questions to ask. Clearly, if a person is pregnant, sometimes the EMS person has a visual cue that lets them know that that's the situation. But in the postpartum time period, that's not the case. And so I think that nugget that you presented is really critical. And so we can be thinking about how we can help, connect resources for folks and educate kind of broadly, even outside of hospitals that may interact with pregnant and postpartum people. The other thing that I would just throw out for folks is a save the date. I don't know if that's is that on our slides, Diane?
We did not put it on there. Sorry.
So we'll just do a verbal save the date for the annual GaPQC meeting will be April 23rd through 24th this coming spring. I think it's going to be in Metro Atlanta again. Just because of the size, but I don't think we have further information on that. Is that correct?
That's correct.
Awesome. And I think those are the big things.
And so the last thing that we have, and Terrell just reminded me again.
Diana had something too.
Okay, please go ahead.
Hi, this is Lachey Waddy. I wanted to just remind everybody I was on the planning committee for our, A1 Empowering Women, which is the post-birth warning signs, and they do allow you to use their information. You can make your own. I think somebody talked about earlier the magnets, and you can use their post-burst, mnemonic that they've created that is copyrighted but free, and you can use that. We've also put that into our EMR system so that, as I think the previous caller said earlier, Piedmont Columbus, that it can be in your EMR so that they're getting the information there, but then we also give them the Save Your Life forms that come in color that you can get from A1 post-birth, and those are in English and Spanish. And so that can be something that could be of assistance. And then earlier with the implicit bias, Dr. Deborah Bingham, who was a part of implementing the CMQCC bundles in California and also one of the spearheading for the Georgia Postpartum Hemorrhage Project with A1, now has PQI, and she does implicit bias training, and it's kind of similar as a learning pathway. So she has something similar to the Harvard webinar, but what I like about her program is that the Harvard kind of helps you to identify that you have bias, but then there's that next step of how do you then deal with it, how do you, how do we then correct that, or how do we improve our care based on the biases that the Harvard assessment allows us to identify that may be there. So her learning pathway kind of has a similar Harvard, experience, but then the additional maybe educational modalities that could go along and partner with that. So I'm going to share that information with you, Diane, and so you can send that out to the group.
No, thank you very much. Thank you. Those are great resources and great information to have. And we are fortunate because Dr. Bingham has been she is a member of GaPQC. She's on the advisory council. She provided a QI training for hospitals, I think about a year and a half ago, that were participating at that time just in the hemorrhage bundle. Excellent and an excellent partner. So we'll certainly follow up with her. But my last thing, Terrell just said, please, everybody that hasn't submitted your first set of quarterly data for hypertension, we're really anxious to get this and get some feedback back to you. But first, we have to upload everything to the AIM portal, and our deadline's kind of running out for that. So we really need the information by Friday, November the 8th. If you would just return that back to Terrell's email address. All right. Thank you, everybody. If you have suggestions and thoughts on any of this or future speakers, the annual conference, the clinical drills, implicit bias training, please call or email anytime. Thank you all.